Morning is maybe it's difficult to perform the colonoscopy, and sometimes we some possibility to overlook some flat type lesion, but artificial intelligence are always there, so they can detect the lesion. Even I drug anyway. So detection maybe AI assist maybe completely in the future, but I think diagnosis is still human is better, you know.
Mm.
Mm. Misawa, Dr. Misawa and Dr. Mori also they are thinking so. Mm.
Okay, we have a question from Dr. Roque Sanz. Sometimes when we perform cold snare resection, we can find at the base of the ulcer a whitish protrusion.
Mm. Mm.
Okay,
Yeah.
what do you think about that tissue? Is that a submucosal tissue, or do you think it's another thing?
Okay. This is also uh, a good question. But I'm sorry. Maybe American doctors already published the paper on GI. I think 2 or 3 years ago, and so I know after dissection, cold snare reaction, some some you mean that like this. So like this, whitey tissue can be seen. So they after dissection, if you can see that some whitey tissue like this, they bite again here, and they send to pathology, and this is their paper, and this whitey tissue is they proved um, muscularis mucosa.
Mm.
Mm.
Okay,
So
okay,
yes.
okay.
There is,
We have here questions from Central America, Guatemala, Brazil, Peru. Okay, there's one more question from Abel Jalif. Okay, the cold snare polypectomy at the entrance seemed to me the obvious choice in order to avoid losing the polyp at the withdrawal, and the suction mark is amazing. Thank you very much. Okay, okay. From Professor Lix, the Brazilian
yeah,
gastroenterologist, Lix
yeah.
Oliveira. Okay, do you think the CAP could help us to do cold snare polypectomy in difficult places in the colon?
Mm. Um. So cap. I don't use usually cap. But I think for the detection, the tiny or diminutive polyps, cap is very useful. So I think cap is useful for the detection rather than treatment. I think.
Okay, there's one more question. Do you think it would be acceptable to increase the 10 millimeters threshold for cold snare polypectomy for sessile serrated adenomas? For example, for 13 from 12 to 13 in the right colon?
Hmm. Um. Yeah. So it's still we need some debate because some Professor Michael Bach group showed some piecemeal cold snare technique for the sessile select lesion more than 10 million size, and they published some papers, some safety and effective feasibility of the piecemeal cold snare rejection, but um, I think less than 10 million size sessile cell lesions sometimes include some dysplasia or so sometimes invasive cancer. So as you know, a cold snare pulpectomy remove the only surface. So if you perform the piecemeal EMR, so some invasive cancer, so a few years later, recurrence can
Mm,
because
mm.
I have some cases. So yes, piecemeal EMR performed for the cystic acid lesion, but some dysplasia containing histology, and 1 or 2 years later, recurrence, invasive cancer can be seen at the same point. So that um, I usually don't perform the course in pulpectomy for the less than more than 10 minute size.
Okay, from Dr. Roque Science, do you diagnose and leave the hyperplastic small polyp? That's an old question.
Less than 5 minute size hyperplastic polyp in the left sigmoid colon. I don't use cord polypectomy or yeah, leave inside too. And right-sided colon, and sometimes I perform the biopsy forceps polypectomy.
Okay, okay. From Clever Nunes from Brazil, if you have a cancer in proximal colon and a polyp of 10 millimeters in sigmoid colon, is it safe to remove them? Do you believe that a spilhem from a tumor can implant at the site of
Ah,
polypectomy?
yes, I know. In UK, so UK, um, yeah, guideline. I saw some possibility of the implantation after polypectomy when insertion technique. But I think in real world, I think I have never experienced such implant and the recurrence cases. So I think yeah, there is some possibility. I know, but I think 99.99999%, almost 100%, it's a safe. I think, I believe, but there
Okay,
is no evidence.
okay. From Pablo
Yeah.
Navarro, a cold snare polypectomy in bigger polyps, more than 10 millimeters, is safe and effective. Usually, injection with dye helps to better recognize the borders of the lesion.
Hmm. Hmm. Yeah. I think uh, it's yeah. We can cut the more than 10 mm size using a cold snare polypectomy. Um, yeah, and yes, but I think that there's no trial, randomized control trial still. But I think less than 10 mm size, there are many papers. But more than 10 mm size, less than 20 mm size paper, maybe a few. So we can perform more than 10 mm size lesion if you inject saline and using a cold polypectomy. But I still now I don't recommend because there's no there's a few evidence.
Okay. Do you use underwater cold snare resection?
Oh yes, sometimes I use so underwater.
Okay, from
Yeah.
Mario Rey from Colombia. When did you decide? When did you decide to make a multiple cold snare polypectomy or an ESD in a 3 centimeters adenoma or larger?
3 centimeters. So I think maybe usually uh, 3 centimeters LST granular type. Maybe it's okay for the cold snare piecemeal resection, but flat LST non-granular types 3 centimeters. I think maybe some invasive area can exist. So we recommend unblocked resection using EMR or EST technique.
A
Mm.
comment from Professor Lix Oliveira.
Yeah.
Great presentation, Sano Sensei. Thank you for
ありがとうございます。どうも。
sharing your, your knowledge. And Okay, in a 2A lesion, do you elevate the lesion before cold snare polypectomy? Well, I think you already said that.
No, 2A, less than 10 minute size. I don't use so any injection before cord publication.
Okay, I think that we are at the end of the questions, and maybe Dr. Asadur wants to say goodbye to the activity. Thank you very much, Professor Sano. It was very nice having this presentation and having all of this interaction with Latin American gastroenterologists.
Yeah.
Let's Dr. Parodi, let's try to put Dr. Asadur on the talk.
Sentiamo.
Okay.
Okay, here I am. Sorry.
Yes.
Yes. No, sorry. I was with something, an incoming call from a patient. Sorry.
No.
No, I was listening carefully until the question of Dr. Roque Sanz. Well, I don't know, Victor. After that question that you make, did you say something?
No.
Okay. I think
okay.
that we would like to have you a little bit more frequent in these meetings, if that is possible for you, because we enjoy a lot of multiple opinions from worldwide professors, and for us it's very, very interesting. So we will expect you sooner, or maybe sooner or sooner. Okay. Okay.
But I can see some friends on the monitor. So thank you very much. I'm very happy to see your face.
Thank you very much.
You're welcome. Yeah, I'm very fine, and I'm still fight against the COVID-19. And
Yeah,
in the future, we meet
Here.
real world.
Okay.
Hope to have you in person.
And salute.
Salud.
Yeah, salute. Anyway.
Bye-bye.
Okay. Bye-bye.
Okay. Bye-bye.
Bye-bye.
See you soon.
See you.
See you soon.
Yeah. See ya.
See you, Sam.